Thank you, Mr. Lume. And good afternoon, everybody. I'm very honored to be here to speak with you, and I want to thank the organizers of the conference for this opportunity. For those of you who don't know, EngenderHealth is a leading women's reproductive health organization, and we are passionate about ensuring that women are able to have the number of children that they want, when they want them, and to do it safely. This is our vision for all women of reproductive age, including adolescent girls, as well as men and boys, families and communities who are so critical in supporting women and girls' sexual and reproductive health rights. Today I'm going to be talking to you about the sexual and reproductive health needs and rights of adolescents from a global perspective, including trends and program best practices. I will also highlight a couple of examples of South-to-South collaboration that EngenderHealth is currently engaged in. Many of you are familiar with some version of the population health pyramid and the implications it has for decision makers with respect to the future of our young people, also with respect to the MDGs in terms of meeting the MDGs. There are over 1.8 billion young people aged 10 to 24 today, the largest generation of young people in history. Close to 90% of all young people live in developing countries where they tend to make up a large proportion of the population. Negative health outcomes of early pregnancy and STIs, including HIV and AIDS, threaten the health of people in the second decade of life more than any other age group. At the same time, adolescents are the greatest hope for turning the tide on STIs, HIV, and early pregnancy. Questions about why and how to turn the tide can only be answered with an understanding of the uniqueness of this age group in terms of the social context that increase adolescents' vulnerability to poor health outcomes. On this next slide, I've listed the range of factors that contribute to adolescents' vulnerability, including biological, societal, behavioral, and structural. I'm not going to go through each of these because I'm sure many of you are aware of them. The thing I wanted to emphasize is that each one of these factors contributes to adolescent vulnerability, and at the same time, taken together, they further increase that vulnerability in terms of magnifying it. Patterns of adolescent sexual behaviors and health outcomes vary according to many social factors, as well as in relation to the traditions, mores, and values within a particular context. Early marriages and early marital sexual activity present risk for obstetric fistula and HIV for young women. Positive trends in recent years include adolescents are increasingly delaying marriage for some. This is due to pursuing education and employment opportunities. Societal norms in many countries are also shifting towards delayed childbearing. Despite these trends, adolescent sexual activity within or outside of marriage is still leading to significant negative adolescent reproductive health outcomes, including unintended pregnancy, unwanted childbearing and abortion, as well as HIV and other STIs. Young people aged 15 to 24 account for 41% of all new HIV infections in the 15 to 49 age group, which means approximately 3,000 young people are still newly affected with HIV every day. An in-depth study of 4 sub-Saharan African countries found that 60% or more of adolescent men and women did not know how to prevent pregnancy, and 1/3 or more did not know of a source of contraception. I think I've got these slides mixed up. This slide refers to young women are more vulnerable than young men. In Kenya, for example, women 15 to 24 are more times more likely to have HIV than males of the same age. This is the slide that refers to pregnancy outcomes. As I mentioned, in this study in 4 sub-Saharan African countries, 60% or more of adolescent men and women did not know how to prevent pregnancy, and 1/3 or more did not know a source for contraceptions. I wanted to touch a little bit on strategies for promoting adolescent sexual and reproductive health. Despite the vastly differing patterns of sexual health behaviors and outcomes, based on the evidence, there are common elements that can comprise prevention and health promotion efforts for adolescents worldwide. And in this slide, I've illustrated some of the key strategies, including access to quality, youth-friendly clinical services, evidence-based education programs that provide accurate information about risks and consequences of STIs in early pregnancy, as well as build life skills for interpersonal communication and decision-making. Youth development strategies that promote opportunities for adolescents to build skills and competencies that allow them to function and contribute to the course of their daily lives within the context of safe and supportive environments. This includes improving completion of basic or primary school, expanding capacity for assuring livelihood and economic security, the meaningful involvement of young people in making decisions about their own needs and rights, including designing and implementing their own programs, and engaging men in addressing prevention of STIs and preventing unintended pregnancies. When these strategies are combined in a comprehensive fashion at multiple levels, they have greater impact. There are good examples of programs that deliver comprehensive sexual and reproductive health services focused on young people's unique needs and expectations. I wanted to share some of EngenderHealth's experience. Based on some initial work with young married couples in Nepal, we have designed a comprehensive program model that focuses on three components: the client, the provider, and policies. This is in accordance with EngenderHealth's overall programming model called SEED, which addresses the supply enabling demand and demand components of providing services for adolescents. In Bangladesh, we are collaborating with two wings of the Ministry of Health and Family Welfare to implement the model in one district through the Mayurhashi project that is funded by USAID. We are using peers to reach young married couples in addressing their reproductive needs. On the request of the Director General of Family Planning, the model is going to be scaled up in 2 districts. In India, with funding from the Packard Foundation and in collaboration with the Ministry of Health, Family Welfare in that country, we are implementing the model through the Tarunya project in 2 states. Here we engage ASHAs, who are volunteer community health workers, to reach out to adolescents as well as raise community awareness about the reproductive health needs and rights of adolescents. To further south-to-south collaboration, EngenderHealth staff from India and Bangladesh will provide technical assistance to other countries in Africa based on the programs being implemented in India and Bangladesh. I now wanted to just touch briefly a bit more about the enabling environment with respect to policy and advocacy. EngenderHealth recently organized a meeting in Bellagio, Italy on reproductive rights, contraception, and informed and voluntary decision-making. As another example of south-to-south collaboration, the meeting provided a rare opportunity for multiple stakeholders from around the world, including young people, to explore key tensions around reproductive health rights. One of the emerging themes during the meeting was well-intentioned laws and policies at the country level often limit access to sexual and reproductive health care. For example, in Bangladesh, implants were only provided to women having at least 1 child. This policy was revised and implants are now being provided to married women who have never had any children. This has had a big impact on the use of implant in this country. In many countries, spousal consent or age limitations on tests and diagnostics that are meant to protect young married women and adolescents. However, they sometimes restrict their access to STI, HIV, and family planning clinical services. HIV disclosure laws and policies in many countries can inadvertently promote HIV stigma and discrimination and bring more harm to HIV-positive adolescents. The meeting in Bellagio resulted in key recommendations that form an advocacy agenda to ensure that informed and voluntary decision-making is assured and protected as efforts are undertaken to expand the reach of family planning programs in 120 million women based on the recent 2012 London Family Planning Summit. And I would just like to close with a success story. At a health clinic in Patna, India, where EngenderHealth is implementing the comprehensive program model I referred to, a young girl, age 15, came to the clinic recently accompanied by an ASHA, the volunteer community health workers. The girl came to the clinic complaining of menstrual pain and anemia, which is common among girls of this age group. During a counseling session with the health provider, the girl also shared that her father had arranged a marriage for her and she would be taken out of school. The girl was very distraught and did not want to get married before finishing her education. In talking with the girl, it was agreed that the ASHA would try to talk to the girl's parents about the situation. The ASHA met with the parents and discussed the importance of their daughter's education, not only for her personal development, but also for the contributions the girl could make to her own family and community. The father finally agreed to let his daughter complete her education before getting married. I think the story illustrates how combining multiple interventions to address the multiple vulnerabilities of adolescents can contribute to turning the tide. Thank you very much.